Good evening or afternoon, actually. Welcome to the State of Black Health 2024. I am Dr. Renee, and we are here at blackdoctor.org. And if you've been with us, then you know we do the State of Black Health every year for the last at least three. And so today is no different. Today it will be 5 hours of great, fabulous information. So, what I need you to do right now is share the broadcast. Share if you're watching on YouTube, Facebook, LinkedIn, whatever you're watching on, please share the broadcast because somebody you know, if not you, will need this information. And so our first hour is all about obesity, the weight of wellness, breaking the cycle of obesity. And we have three obesity medicine physicians with us, and you probably didn't even know that was a specialty. But these ladies were trained in one thing and then went and learned and got more education so that they could work with us women, men, children on obesity. So I'm so excited because needless to say, it is a hot topic in the news these days. All the weight loss drugs and how did this one lose weight and should I use keto? Should I use Weight Watchers? Should I? So we are here to hopefully get some of those questions answered. Please type in the chat. Let us know where you're watching from. Also, don't forget, if you have questions, type them in the chat and I will do my best to look through them and try to get them answered. Okay? So here we go. Good afternoon, ladies.
Hello.
Hi.
Hello. Hey, how are you?
Oh, I'm great. So today we have Dr. Yolanda, Dr. Tiffany, and Dr. Catherine Toomer. And so I am so excited to have you guys because you guys are a wealth of knowledge. But real quickly, we'll start with you, Dr. Yolanda. Just tell us briefly, give yourself an introduction of who you are.
Sure. I'm Dr. Yolanda Lewis-Ragland. I am a pediatrician, as well as most of us, a bariatrician. I got board certified through the American Board of Obesity Medicine about almost 10 years ago, working in Southeast DC with families, recognizing that in one of those, I work in a community of, lower resources and community that's pretty exploited when it comes to, all the social determinants of health. And so in my community, lots of diabetes, lots of obesity, other chronic diseases that were very much preventable. And so started focusing on weight loss for children and pretty much now for families. And so I've been doing this I've been working in my community for about 20 years and been doing obesity strictly for the last 12 to 15 years.
Dr. Tiffany?
Well, hello, everybody. I am Dr. Tiffany Lowe Clayton, also known as Dr. TLC. I am a family physician by training. Have been doing family medicine now for about 24 years. I certified in obesity medicine and became a diplomat of the American Board of Obesity Medicine about 7 years ago in response to all the patients that I saw who were not just dealing with obesity, but also dealing with chronic stress as a major factor, a major underlying factor in obesity. And so my practice has really shifted to deal more with obesity, stress management, eating disorders, and things that are associated with that. I am a practicing physician in the Raleigh, North Carolina area at Wake Med Health and Hospital Systems. And I am also an assistant professor at Campbell University School of Osteopathic Medicine, here where I'm the director of clinical education. And, I'm passionate about this. I'm passionate about this not just in treating patients in general, but especially in Black and Brown patients who are so disproportionately impacted by obesity and the other comorbid conditions that go along with it. And so I'm happy to be here and share, and hopefully you'll be able to learn a lot today.
Dr. Catherine?
Hello, I am, like you said, Dr. Catherine Toomer. I'm also a family physician, have been for about 25 years now, and have been, although people describe me as an obesity specialist, I'm actually a weight care specialist. I help people gain weight as well. So I use a biopsychosocial approach to any chronic disease, including obesity. And so I go after the cause. And the cause is often related to things that are very much within the wheelhouse of family medicine. Having lost over 100 pounds myself, using the same program that I used for myself when I needed to save my life, essentially. And I've used that in underserved areas with my patients in rural South Carolina, which is where I am now. And then later, now I teach other physicians how to create comprehensive and compassionate programs for their patients within their practices.
Thank you. Awesome. So, first off the top, let's talk about just a few of the diseases and conditions that obesity is probably the cause.
Meaning
Any
caused by or causes?
caused by.
Caused by.
I
Well,
mean, go ahead. Sorry.
I would say that, obesity is one of those things that, a lot of people think that all you have to do is just eat less and move more. And it's such a myth because we know that when it comes to people who have issues with obesity, it's so much more than lifestyle, although it's really important, an important part of maintaining a healthy weight. But there's so many factors that go into why a person may struggle with their weight. It's not a moral failure. And that's the very first thing that I want to say is that it's not a moral failure that someone struggles with their weight. But there's so many different components that are involved, from a person's genetics to a person's environment, what they are around, all of the things in where that person may live, eat, sleep, play, and just be at for a regular period of time. Some of the struggles that they may deal with, whether it's issues with housing or issues with food, and then also just their culture, how they grew up, and those cultural norms that really go into play in terms of why people make decisions that they make, whether it's from their eating to drinking to doing whatever they may do in their normal life. And so, when we think about all the things that could potentially cause obesity, it's not just one, but the one thing that we do need to recognize is that obesity is complex. And it's a chronic disease, just like we would think about any other disease like high blood pressure, diabetes. We really have to think about obesity in that way and really treat it as if it's a complex disease to be able to successfully help people not just lose weight, but keep weight off.
So I have a
Yeah, I'm glad.
question. Do they consider obesity as actually a condition? So then that is in the DSM. Okay.
Yes.
Yes.
Yeah.
Yes,
And
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 the
I'll
more we talk
yeah.
about it, and I'm sure you all can say the same. The more we talk about it, and the more we begin to have discussions like we're having today, the more it will be recognized as a chronic disease, the chronic disease for that it is.
Yeah. And I'll piggyback off of what Dr. Tiffany said, especially because as a pediatrician, right, you're talking about obesity. We're often seeing it at very young ages, right? I mean, we start categorizing obesity by age 2, right? And it's because up to age 2, we don't really put those labels on because, there's a growth curve and a process that's occurring, and prior to that age we just use percentiles, but we can determine that, and obviously that child's going to grow taller, and all these adjustments can be made. But specifically to Dr. Tiffany's point, the environment that child's in, it's multiple, it's obviously it's multifactorial. That's the point I'm making when it comes to obesity. And so that child is basically subject to the culture they're in, the family circumstances they're in, whatever the habits are of that family, and again, the genetics of their family. And so we have to be very careful not to think of it as anything other than just a condition. I talk to my families about weight and overweight or obesity, just like I talk to them about asthma or, an ear infection or any other illness or, condition, because I believe it's once we start to think of it as a stigmatized issue that some providers don't have the real conversations. And I've had conversations with people who their providers have never really talked to them about the fact that what their BMI is or what it could or should be. And I know the BMI specifically is not something we always stick to as you get older, but when you're younger, we can actually have those conversations much earlier and be a little bit closer to where the child at least have a goal for the family. But there's so many people who won't have these conversations, including medical providers. And so I think that we do an injustice to families when we don't have the conversation about the holistic care that comes with obesity.
And I think that for the younger people, especially, it's a slippery slope. You don't want to, you don't want to put your kid on a diet, but you also don't want your child to end up with type 2 diabetes at 10 years old.
Well,
Exactly.
you don't want to put yourself on it. Let's be very honest. Like, often what happens is the family doesn't want to make those changes. It's not if I said this child has asthma and needs an albuterol pump or needs to do X, Y, and Z, that's what they would do. The issue becomes when I have these conversations and make recommendations about not only what the child needs to do, but the fact that in order for it to be sustaining and something that the child feels good about and comfortable with, then the whole family needs to participate. That's when we begin to have the problem. One of the reasons I got my my certification as well with the American Board of Obesity Medicine is because I realized when I was just giving this information as the pediatrician to families and parents about their child, it was very easy for them to compartmentalize. Oh, your doctor said you need to X, Y, Z. So when I began to say, no, that may be true, but you as a family need to do these things because this child needs to, more is caught than taught. So the child is going to do more of what they're shown if you're incorporating these changes. And just because you have one child that's overweight and one child that's considered normal weight doesn't mean your normal weight child also can't make these changes, drinking more water, eating more, fruits and vegetables, having a more plant-based diet, getting off of processed foods, as well as getting more exercise. There's all kinds of things that we talk about, but it's so interesting how people try to compartmentalize as parents and say, oh, this is for the child, but the family can continue to do this. It doesn't work that way. The entire family has to adopt and adapt these changes for it to be sustainable.
And we often see that with parents in along any lines. I mean, we try to tell people that the children don't shop, the children don't cook, and so it really does have to be a family event. But I think that something that I like to look at is what we call as a biopsychosocial approach. I mean, we are humans, and then with humans, everything we do has a biological cause or a psychosocial cause, a psychological cause, a social cause. And when you look at where it comes from, it's very easy then to help people make those changes. And I think that one of the things that happens, and we know this to happen, is that there's a lot of bias and prejudice in medicine. And it's no different for people who are overweight. And sometimes they're not necessarily overweight, they just have too much fat in their system. So that's something also that we need to talk about, because people who are thin think, okay, they're fine because they're not overweight, when actually their body composition is off. And so that can also be a problem. But however, when we start looking at some of the biological causes of why people gain weight, and we start going after those causes, unfortunately, within medicine, what we've been told is it's, calories in, calories out, how much you exercise. But we all know that because of our apprentice system, that misinformation gets passed down from generation to generation of physicians. And then when you add bias and prejudice on top of that, we have a disease that's being undertreated and but overly regulated, unfortunately. And so that's the state we're in right now.
Dr. Catherine, I cannot agree with you more. I'm an osteopathic physician, and when you said biopsychosocial model, that's really like what our center is. And when we talk about why people struggle with their weight, I often tell my patients and providers alike, I say, listen, the unhealthy weight is the manifestation, but there's always a why behind the what. The question is, why is this person struggling with their weight and what's going on? And you can't separate a person's sociology or their environment from their physical health. It all kind of works together. And when one of them's off, all of it's off. And not just their environment, but their spiritual health, their mental health, their physical health. all of it is in play. I'm a stress expert. And one of the biggest things that I see is that we don't take care of the elephants that are in the room, essentially, taking care of chronic stress and the stress that we have as individuals, and how that can really create issues in our body, create a stress response that takes our hormones, our stress hormones, to a whole nother level, and then also makes us, manage those stressors often in unhealthy ways, whether it's by overeating or having other unhealthy behaviors that then lend itself to a person struggling with their weight. I often say that, ever since I got diagnosed, got boarded for obesity medicine, I've treated more depression, more anxiety, more emotional eating, and other eating disorders than I have in almost my entire career. But it really is having an understanding of all of the complexities that go into a person's struggle with their weight. You have to really understand and ask the right questions so that you can really help that patient in the best way.
Exactly.
And
But
I
then you also have to,
Go
oh,
ahead.
sorry. Go ahead.
No, I was just going to add that I think the other thing to remember, or that we're sort of saying it, I think, but we're also kind of talking around it, is we talk often about, and maybe it's because I'm a pediatrician, I talk about social determinants of health, right? We're always talking about that. That's something I think we don't talk enough or frame it enough, that obesity is connected with your social determinants of health. Because every time we talk about social determinants of health, about any other disease process, then people sort of understand it. But we're saying, yes, it's where you eat. If you're in a food desert, which most places are not food deserts, let's be very clear. Most places are what we call food swamps. There's food around, it's just not healthy food, right? So people are getting their meals or groceries or things that they normally eat at fast food places, bodegas, the 7-Eleven, the gas station, whatever it is, they're consuming more times than not throughout the day. And so there's these food swamps. Then if you're in a neighborhood where you can't get a lot of recreation or exercise because maybe a dangerous neighborhood, the infrastructure may not be there. And so you're relying, as a child, for instance, you're relying on a school system that has physical education. Well, guess what? They don't have physical education the way they used to have physical education. So kids now go maybe one day a week getting physical education the first half of the year, and then the second half of the year it's they what we call rotate off. It's another group's turn, because they've not incorporated into their days. We had recess every single day, going outside, as well as PE every single day. That's not the norm in all schools anymore. So kids are getting less and less opportunities to get exercise. They're stressed out much more than ever before, right? As Dr. Tiffany's saying. So you got social media, and you got, the sedentary lifestyle that comes with that, the video games and the constant stimulation. There are so many factors. And then when you're talking to someone about giving them these ideas about things that they can do, let's say we talk about a plant-based diet. They may not have access to plant-based foods. And so it becomes very difficult to have conversations about some of the things that we could do differently when your circumstances are not really conducive to making some of these changes. So until we really frame this about these social determinants of health, where you live, where your family works, whether they're overworked and underpaid, right? All of these things matter when it comes to the types of food that you get, your access to food, your access to activity, and then your stress levels, that cortisol, that constant stress hormones that is pumping into that and giving you that fight or flight, that toxic stress. That has an effect on your response system to whether you're overeating, and just not even the poor digestion. If you are eating, even if you do get good food substances, you could have poor digestion because of that constant stress.
Dr. Yolanda, I wanted to add on to something you were saying, because when we were talking about social determinants of health, and when we really look at who's impacted by suboptimal social determinants of health, and then we compare that to who's really impacted by obesity and other chronic conditions like high blood pressure, diabetes, and really many of the chronic conditions that we see, we often see that we as Black and Brown people are impacted mostly. It really impacts us at a disproportionate rate. When we're talking about those suboptimal determinants of health, or putting us in those food swamps where we cannot get to access a food, it was really intentional. And I want people to understand that, when you think about social determinants of health or health disparities and not being able to get the best health what we need, it was an intentional, intentionally created to be that way from years and years and years of just, segregating and, putting people into these redlining districts and, really putting areas around so that those who are Black and Brown are at a disadvantage when it comes to getting the things that they need. Even when you, cancel out for things like economics, or, those individuals who say, okay, well, I made it, so I have a higher social economic level, they are still subject to having suboptimal areas because of where they choose to live, because they want to be around people who look like them, who they identify with. And so, what we're seeing in terms of health disparities when it comes to obesity and when it comes to all these diseases is not by accident. It's intentional. But once we know better, then we have to do better, and we have to work together as a community to be able to advocate for ourselves, and then to also be able to make better choices, whatever those choices are, so that we can start to, bridge the gap of health disparities.
And so
I think
that's
something we also need to continue.
go ahead.
Go ahead.
No, go ahead.
No, I was going to say something. I mean, we're talking about the state of Black health, so this is something we have to take in consideration. Our reactions to fight or flight, our stress reactions, are hyper. And the reason that is just because of epigenetics, and because high cortisol levels does change our DNA, and that DNA gets passed on. And so what happens is that, we're talking about stress eating or getting stressed and then changing our behaviors. It actually changes our biology. And so it changes our biology. It creates insulin resistance, which then creates issues with our brain, which then creates issues with our cravings, which then creates issues with our moods. And so it's this vicious cycle of, and it is partly genetic. And so even when you do take away when you level off for socioeconomics and education, we still suffer at higher rates, and that's part of it. But that also means that we can make changes, but understanding why those changes are affected by what's going on around us. And I think that is, food deserts obviously is an issue. I don't live in a food desert, but I still have higher rates of diabetes in my family. So why is that? And so we have to take all of those things into consideration when talking about obesity rates and health rates, and what biology does to our choices, to what food does inside of our body, what we do when we are under stress, and the rest. And so I know I'm talking a bit in circles, but it is a vicious cycle. That's what it is. It starts a spiral, and we have to figure out ways of going to the cause so we can spiral it back the other direction rather than down, because that's where we're going at the moment.
I think you're making absolute sense, because when we're talking about how our chronic stress affects our biology, or affects how our body functions and how our hormones play out, it is those micro stressors that people deal with, those things that you may not necessarily understand that you're stressed, or you may not necessarily know that you're stressed. But when you're dealing with things like, living in an area that may have increased policing, or living in an area that may have a place where you can't get healthy food, or living someplace where you can't get your kids to school safely, or if you can, even living with a place where you may be dealing with microaggressions at work, or whatever the case may be.
Or walking into a room and people thinking that you're the first food service person rather than the doctor.
Right. That's all chronic stress. That is all chronic stress. And because it has become something that we live with and we deal with, we don't realize that may be underlying some of the reasons why we may emotionally eat, why we may grab sweet stuff. I never heard anybody say, "Oh my God, I'm so stressed. Give me some carrots." No,
Right.
what are we going after? We're going after chocolate. We're going after soda. We're going after candy. We're going after all the things that have low nutritional value, but that we consider to be, comfort foods. And so ultimately, we see things like our hunger hormones start to increase and our fullness hormones decrease. And then we start getting, going after foods that's going to increase our happy hormones like dopamine and those types of things. And that ultimately ends up lending itself to a society that may be, emotionally eating or just taking in too much. And then they're not exercising, like Dr. Yolanda said. We're not getting physical activity, and we're watching TV, or, we're just sitting around and we're not doing anything. And we don't even want to talk about what happened with COVID, where everybody went to remote work, right? Everybody was remote working from home. Nobody was moving. And we saw the obesity epidemic just skyrocket during COVID because of that.
But I want to add before we go into some things that are new, there are things that we actually this could go on probably a good 2 hours because there's so much to talk about, right? But one of the things that we kind of don't talk about, right, is the fact that in the last 30 to 40 years, the trend has been so much bigger than it was prior to that, right? And why is that? So as you're talking about it being purposeful, the redlining and all the things that happen in our communities, what was also purposeful is fast food restaurants, I don't even what's the word for 10 times as much, because I can't say quadruple. They're like every single place you go, and there's so many of them in all the countries now, right? In fact, where they did not have these restaurants, when you traveled, people had less obesity. Once some of these restaurants, I'm going to be, said that I was specific about a particular place, but once some of these places popped up in places like St. Thomas and Dubai and, these other areas, then their obesity exploded. So one of the things I'm going to talk about is with kids, for instance, just like you were talking about, we know in ACEs that those all of those chronic stress, toxic stress situations changes the structure of the brain, like how children actually respond to stress because of their adverse, episodes in childhood. Well, the problem is it never stopped for us. We're still experiencing what we call ACEs in childhood, in our adolescence, and as adults. And so we cannot stop having these toxic, and it's so ridiculous that yes, we can show that in ACEs when your brain is still developing, but the fact is we're not even continuing to study what these hormones are continuing to do, because we're constantly bathed in these stress hormones, this intergenerational trauma, all the structural racism and all the stuff. But the stuff that's purposeful is that we didn't have vending machines and sodas and machines in our schools when we were young. We didn't have, in fact, I remember when the candy store opened at my school in high school, because they saw that people were making so much money selling candy. They decided in my bookstore to start selling candy. And all of a sudden it was the biggest thing they sold. It used to just sell books. These kids are constantly bombarded. And it's a shame that we allow more vending machines and candy in schools, but we've allowed them to take PE out of schools. So but again, it's in communities where we don't go in on the school boards. We don't go in to them and say, hey,
or PTA and stuff.
Take these out of our schools. It's the moneymaker in the school, and the school needs the money. So we're allowing this. So when we talk about purposeful, there's like so many places to start. Because our kids are suffering.
Well, because of also the hormonal disruptors that are in the preservatives as well. Yes. And so, and then not to mention the pollution within the environment and the plastics and all the rest. However, when it comes to an individual level, because sometimes a problem just seems too big and people are just like, well, I don't even know where to start. So you start with yourself, and you start with intentional stress reduction. And there are lots of things. And a lot of things in our community, often people might say, well, that's not what we do. Well, we do it. We have yogis. We have Pilates instructors.
Right.
We have, people who do meditation, and
I'm a
and
transcendental
I'm
meditation
I'm a
teacher.
certified
Me,
hypnotherapist, and I do it for deep relaxation.
me too.
That's all it is. And
Mhm.
it's just, and you can self relax, or you can help
You'd be
somebody.
amazed the things you can find on the phone. There's an app for meditation. You can go
Exactly.
on
There's an app
YouTube
for
and do
everything.
Pilates.
Yes.
You can
Exactly.
go on YouTube and figure out yoga. I mean, you do not have to pay money for a lot of
Money
these
to
things,
do
but
anything.
Can,
And the
can
other
we
thing
even
that
start
it will
before
save
that?
your life.
we have to
Save
also
your
be
life.
very, very careful with our language, because so often what we do is we put the onus on the individual, which it
Right.
is
Hmm.
for the most
Right.
part. However, because we make choices. But one of the things that I think that we forget is that our brain is glucose driven.
Yeah.
So
Yeah.
when we are under stress and we have glucose resistance, it
Mhm.
changes what our brain does. And that's why we crave sugar. That's why we crave those carbs. It's not because we have some willpower issue. It's because our brain intentionally does that, because it's not getting the glucose it needs because of the resistance.
Yeah.
And
And
can we
so,
just even
and so when
start
we let
one
people
step?
know this, so that they don't constantly beat themselves up, and it becomes this vicious cycle of, I hate myself, I'm doing this, and then
Right.
it just changes the environment that food gets consumed. And so empowering individuals to say, this is not all your fault, but there are things you can do, I think lends itself to better recovery than, not only just identifying the problem and the why, but also to give people tools that they can use to then, as an individual, to then start. And I think stress reduction, learning how to manage our emotions, learning how to manage our reactions to things, doesn't just help us, it does help our children, it does help the rest of our families.
Mhm.
And everybody knows, when it comes right down to it, it's the woman who's the foundation. And the reason why society is upheld is because we can withstand high levels of stress. We all see what happens when other people are stressed. But if we were somebody who reacted to stress and broke down with stress, society would come to a standstill. We
Well, I
have
think
to
it
give
goes back to
over
what you were saying, Dr. Toomer, when you were saying, when we were talking about the biopsychosocial model,
it.
because I think if we go all the way back to the beginning, first of all, we have to understand that in the Black community, mental health illness is real.
Mhm.
And it's
It is
something that
very
we
real.
have to stop stigmatizing as a
Mhm.
community, or stop saying that, we don't have it, or that if you are depressed, or if you're dealing with anxiety or any of those type of things, that it's something that's bad. It is the person who suffers in silence that's the person who's in danger. The person who can actually talk and say, I have issues, to even be able to understand or find those resources, is going to be the person who is in a much safer space, and then be able to make those healthy choices. So, before I can even understand what app I can use or where I can go, I have
Right.
to say I have an issue. I have to
Right.
say I have a problem. I have to say that, you know what, I developed an unhealthy eating behavior when I was 5 or 6 or 7, because I had some adverse childhood experience that occurred, or I had someone who may have been touching me inappropriately, or someone who may have bullied me, or
Mhm.
someone who may have told me certain things, or when I was having a bad day, my mom or my grandma gave me cookies, and they made that was my comfort food. So now when I'm upset, I am going to take these behaviors that I learned as a child and carry them with me into adulthood. And now I'm going to emotionally eat, or I'm going to eat foods that are not healthy for me, because I learned these things as a child. We know that you talked about something called epigenetics, or the environment in a space where women are pregnant, or even before they're
Yeah.
pregnant, and how it can create changes in our
Mhm.
genetics to occur.
Our
But
brain.
we know that when a person has exposure as a child, it increases the rate that that
Mhm.
person will deal with obesity as an adult by
Mhm.
almost threefold. We also
Mhm.
know that if a person has one parent who has a weight issue, it increases
Yep.
the risk that their offspring will have issues with their weight by 50%. If they have two parents that deal with a weight issue, it increases that risk by 75%. So
Mhm.
you also have to
Mhm.
look at your family history. Does your family struggle with weight? Because if they do, then you have to realize that the risk that you may deal with obesity as an
Mhm.
adult is increased. But even though it's a risk, it doesn't mean it has to be your reality. You just
Exactly.
have to understand what to do, how to eat better, improve your physical activity, manage your stress, and you can help yourself maintain a healthy weight. I always tell my patients, especially patients who have issues with their weight over a period of time, that when you get to a better weight, it's not an end. Having weight loss is not a destination. It is a lifestyle. It is a journey, and you have to treat it as if it's a chronic disease. I tell patients, you're not going to get over your weight. You're going to get control of it. And then the thing we want you to do is teach you what you have to do to maintain control of that weight. This is a daily thing that people have to do. And we really have to be open and honest with ourselves, and really be in tune with ourselves to make sure that we can make mindful decisions, and then seek help when necessary from somebody who knows what they're doing and knows what they're talking about to be able to help you not just lose weight, but keep it off.
So I think we have to get to solutions.
I was going to say,
I
you mentioned something, treating it as a chronic disease.
Right.
Treating it as a chronic disease.
Yeah.
And the thing is that there's this resistance to treating and so this is my philosophy. Why make someone push a boulder up a hill when we have tractors to pull it up?
Right.
Once it's up there, you can do all the things you have to do to keep it there. So once you've corrected people metabolically, you've corrected people psychologically, you've corrected some of their social things over time, once they're there, then you can start saying, okay, now let's start building muscle to take place of the medication, or at least reduce it. Let's make sure that your cardiovascular system is improved by doing different types of exercise that will do that, but not stress you to the point where it drives your cortisol levels up and makes everything worse. I mean, there's different things, and I think that it can be it's a multifactorial cause, and therefore it should be a multifactorial fix. Right. And I think there's this resistance to, when in any other chronic disease, when someone walks in and that disease state is out of control or just out of range, we immediately treat, and then we start talking about lifestyle to help people. We don't tell them right off the bat, you work on your lifestyle, and then we'll decide if we're going to treat you, unless it's just mildly out of range. But if someone's already obese, that's an out of control hypertensive. We don't let people walk around with out of control hypertension.
I was going to say real quick, as for the children part, because again, a lot of times when we were talking about adults, right, this is where we are. One of the things that you all were saying that's so vitally important is changing the understanding of what's okay in the community, right? So many things that we adopt as it's almost like that's what I do, or that's what my family, I'm big bone, my whole family's big, there's these things that we sort of adopt. Well, there's also things that we just sort of say, that's what happens in our community, right? So we can change that by just exposure. So like you said, right, these apps and all these things, honestly, we're so communal that if we start creating community around many of these things, if you created community around meditation, it would be more accepted. If you created community around yoga, bike club, if we purposefully created community around these things, and we make so many things that are bad look good. We've made cigarettes look so cool that people were, we make cigars and brown liquor look so cool that people are like purposefully going to cigar bar. It's driving up our hypertension and giving us, and we have the highest heart disease. The things that we make look cool, everybody does it. We have to be purposeful at making these healthy things look cool, right? How we got to modify. I love the idea. Like I wrote a health conscious nutrition book, and I call it soul food therapy. Soul food has taken on such this, bad connotation and bad name. And for me, it's an acronym, and it's savory, organic, unprocessed living food. So recognizing there are things that we're doing that we've made look good, but are not good for us. When we turn that around and make things look good that are actually good for us, that's, I think, where we'll start to have this traction. And in my practice, often with kids, like a child will come in, it's a family and they're getting shots, let's say just regular vaccines. The first thing a parent comes out of their mouth with is, oh, once you're done with your shots, we'll go get some ice cream, or we'll go get nuggets. I won't say from where. We're going to go get this. And I stop them and I say, you know what? How about mom, dad, you promise to take them to the park when they're done? The truth of the matter is they just want something special to do, to spend time with you, that's going to give them the endorphins they need. That can be handled by going to the park. That can be handled by going ice skating. That can be handled by going and clear. And what happens is the parent goes, oh, okay. They have to change. They begin to change their habits of what they treat that child with. So as Dr. Tiffany said, you're not remembering when I have a bad day, I'm going to go get ice cream. When I have a bad day or something happens, I go for a walk, I go for a run, I go play, I go skating, I go do the thing that my parent or my family, my guardian did to make me feel better as a child. So and those are the things that I often have to talk to parents about. Just because this is something you did as a child doesn't mean you have to perpetuate that in your own family structure. And so I just think that in our communities, we have to start making these things look good, right? And be attractive and create community around them so that we can start to get some kind of traction.
Dr. Renee, you mentioned solutions and, how do we help this? And, one of the things that I will say is studies are clear. Something as simple as when a person deals with their weight, something as simple as 5 to 15% of their weight loss, and really 5 to 10% of their weight loss is going to make a significant difference in that person's life. We know that when it comes to medical issues, there's over 200 disease states that are associated with a person who struggles with their weight. A person who has obesity, there's over 200, from diabetes to high blood pressure to arthritis to all of these things, and including, psychological diseases, anxiety or depression. But if we were to treat a person's obesity, so starting from the inside and working our way out, we can really help those individuals not just improve, but reverse their medical conditions. And so we're all obesity medicine specialists. We're all obesity medicine specialists. And we really focus on, 4 main ways to do that. One, Dr. Yolanda has already talked about it. We have to work on behavior modification. We have to work on helping patients develop healthier behaviors when they are stressed or, in response to comfort. And then we have to, obviously work on our eating. Eating and physical activity are key. Getting a healthy eating plan, not diet. Diets die. We want healthy eating plans, whichever plan you choose, whether it's low carb or low fat or whatever the case may be. The care really has to be individualized, and working with a provider is going to make you do that. But then medication is going to be important as an adjunct to lifestyle modification. That's going to be important as well. Getting on the right medicine and off the wrong medicine, because there are some medicines that people are taking that can actually promote weight gain. And having a provider and doctor look at your whole picture, not just one piece or another piece, but really look at you as an entire person and look at all the pieces that could be lending itself to why you may be struggling with your weight, including some medications like insulin, for instance. For patients who are diabetic, we put patients on insulin, but insulin can actually cause weight gain. Going through your medicine list and thinning that out. Also, putting you on the right types of medications as an adjunct to diet and physical activity. That's really how we're going to help patients be able to lose weight.
So let's
And I
talk
think
about
also
weight loss drugs, because we're going to run out of time in a minute.
Well, there's a couple things.
Go ahead.
So the weight loss drugs are good, obviously. Now, and I'm just going to talk very quickly about my history, because you're just basically, I was an insulin dependent diabetic, and I was over 100 pounds overweight and went to congestive heart failure. And the only way I was able to survive was by weight loss. And this was before the advent of GLP drugs. But the first thing I did was treat my depression.
That's right. Oh.
Depression affects motivation. And if you're depressed and you're anxious, you're not going to be motivated to do many other things that are necessary. So that was number one. Number two is getting diabetes under control. And the one thing you can do, diabetes is a meal by meal control. You can control your blood sugars one meal at a time, right from day one. And so just by managing carbohydrates, by maximizing proteins, you can do that. And that's what I did. And then later, what happened, my ejection fraction, which is the way our heart functions, just for those of you who are not medical out there, started dropping. The first thing my cardiologist did was put me on this medication that has been known to improve heart function. This was 10 years ago. It was a GLP-1. My ejection fraction doubled. It wasn't for weight loss. It wasn't even for my diabetes, even though I was already a diabetic. It was simply for my heart. And what that did, though, is that every single cell in our body has receptors for glucose. And so when those cells are made to use glucose more efficiently, everything works better. Every organ, every end organ, every end, small vessels, dementia, blindness, kidney failure, all of that gets reversed when we start correcting for glucose dysregulation. It affects mood, it affects our food choices, it affects how food acts once we've eaten it. I mean, so I think that the fact that we have a GLP-1 and what's called GIP also combined, which is essentially a way to help our body regulate glucose, knowing we have a genetic component that predisposes us to diabetes. Just because a textbook says you're not diabetic till you're 6.5 hemoglobin A1C, our bodies don't read textbooks.
That's
it
right.
starts way earlier, and stress starts that process way earlier. Insulin resistant. And if we can prevent diabetes by treating it now, I don't see why that should be step number one. Treating psychological issues, treating glucose dysregulation. And then once all those things are regulated, it becomes so much easier to hone in on the lifestyle changes, because those changes become easier. Your muscles are more efficient. They're not fighting with fat cells for that energy. And everything just gets so much easier, so much more efficient. And then when you go into maintenance, it's golden.
But I think what you're getting at, though, is what Dr. Tiffany's saying as well. And it's what Dr. Renee started with. You have 3 physicians on here who learned something extra to really grasp this information, because it is not taught in medical school.
No.
The other thing is,
the opposite.
let's be very clear. Nutrition is not taught in medical school.
No.
That's what people are people assume that when you go to your physician, they can actually have an educated conversation about weight, right? About weight gain, appropriate weight, the way to lose weight, the way to gain weight. Because again, like Dr. Catherine, I also deal with weight gain, and especially in young teenage boys who can't put the pounds on, and they're so thin that we have to talk about weight gain. But the point I'm making is, this is where the tragedy is that this information really should be common knowledge taught in medical schools and for medical providers. But you have folks here who have to talk to other providers and teach other providers about how to feel comfortable with this information. And I believe, hopefully it gets better, but I hate to be controversial, but when we start medical school, there are certain medications you learn the body anatomy, the disease process, diagnosis, and medication. But we never did that with obesity, as Dr. Catherine was saying, right? You learn,
we learn how fat is made.
Right.
But we aren't taught how to apply that knowledge to how to unmake it.
But the point is, we didn't learn the medication needs to be put right on, like with this disease process. And now it's becoming almost, controversial to use the medications, and it should not be.
It's only controversial because of the bias. The underlying controversy is still based on the prejudice and bias,
stigma,
phobia. If this were any other disease, nobody would even care. But just like you have micro solutions, you have macro solutions, and you have micro solutions. Individuals care about the micro. They're like, okay, what do I do now? What do I do tomorrow?
And find someone who is educated. My point was finding people who are actually educated in being able to manage these processes and not be so upset that your primary care is not necessarily going to be able to have this educated conversation, because it hasn't necessarily been taught in medical schools. Was the point I was making, is you need to find specialists.
Well, absolutely. And I agree with that, because everybody is not trained. And I will tell you that when I certified in obesity medicine, that's when I realized how much I didn't know. how much I did not know, and how complex the disease was. And when we're talking about medications, as an obesity medicine specialist, when I see patients come from primary care physicians or from OBGYN or from wherever they come from, often they'll come to me on medications. And, I often find that doctors pick the medication of choice, whatever their medication they're comfortable with, they pick that medication of choice. But when it comes to medications, there's so many different ones that we can choose. And there's no one size that fits all, right? There's no one size that fits all in medicine. There's no one medication that's going to fit all for every person's issue. It's really about, what are we treating? Are you treating a person's craving? Are you treating the fact that they may overeat? Are you treating the fact that they may eat at night? Are you treating the fact that they may emotionally eat? There's so many reasons that we have to understand why a person eats to know which medication we put them on. Let's say it. Let's say it right now, because everybody knows the biggest craze out there right now is the shot. I get those patients coming in saying, doctor, I want my shot. I need my shot. I heard that shot. I can get it once a week. Whether it's, Wegovy or Zepbound, or, the ones that are originally supposed to be used for diabetes, like Mounjaro or Ozempic or all these other medications, they want it. But when you are going on these medications, and they work, and they're extremely powerful medications, and the studies are clear, they do work. But what the studies also are clear about is that when you put a patient on medication, it has to be an adjunct in addition to lifestyle modification, diet, and exercise. All of it has to work together, so that you can really help the patient get to that place. And so, when we're talking about these injectable medications, really, I agree, Dr. Yolanda, go to somebody who knows what they're doing, who knows what they're talking about, and who's going to be able to help you develop a comprehensive plan to eat right, move the right way, set goals that are reasonable for you, not goals that I never tell my patients, I want you to do A, B, and C or D. I ask my patients, what are you willing to do? Because they're more likely to do what they're willing to do other than what I tell them. And then on top of that, then let's talk about which medication is going to be best for you. And then how do we make this an overall lifestyle, not just a moment in time?
And I think with so many out there, one key component, and this is what I tell people: if the person telling you something's wrong with you is also selling you the solution in medication, find somebody else. Ooh. Because I mean,
that's a good point.
You can't tell. I mean, I'm sure there are people out there who are selling medications who are very, very good at what they do and are very honorable, but there's a whole lot of others that aren't. And so a good way to know, if you are seeing your doctor who's trying to help you and is not trying to sell you anything in the process, no vitamins, no supplements, no, the
Energizer shot.
Exactly. No shots, right? no B12 and all the rest, then you can trust that person, because that means they're not using weight loss as a money-making entity. They truly care about what it is that is affecting your health, and they want to help you with it. And that's a good, because we're getting harmed by a lot of weight loss is a multi-billion-dollar industry, and most of the industry is designed for you to have to come back to become a repeat customer. And so it's not designed for sustainable weight loss.
That's the point.
And so you have to go to someone who has health in mind. Your weight is important, but if you're only going to someone for your weight, more than likely your desperation is showing, and people are going to take advantage of it.
And I think it's managing expectations, right? Because I think the whole point too is, if you're doing medications because of diabetes, it's very likely you may need to do this for years, right? You may be on this medication 5 years, 10 years, and I'm not, we don't know. But if you're doing it for weight loss, it's funny. I used to be a medical director for a weight loss clinic when I first came out and got my certification, and it was very difficult to see adults with my certification. So I could only do so much with kids. So with adults, I was like, oh, I'll work at this place. All it was pretty much the B12 shots and the medications not to eat. And I came in with all of this information about diet and, how to choose certain foods. And that was like, we don't want to tell these people this, because again, a lot like some psychiatrists who want you for 20 years, these weight loss folks would have people for 10 years, 50 years. I'm like, you can't have a good business model if people are still coming to you for 10 years for weight loss, right? So when it comes to this, it's managing expectations. When you give the lifestyle changes, as Dr. Tiffany is talking about, you are going to lose this weight, and it really should be in a reasonable amount of time. And then the real work starts, like the real work of what you're going to eat, how you're going to eat it, some of these different things. And these medications, we want you to still manage metabolically, but we also got to work on all of the other stuff that comes with that. And a lot of times, if you have people that are just selling you things and they got you going on this, for a long time, the question is, what is the end game, and how do we manage expectations? Like
the same way you manage the expectations for any chronic disease. And my feeling is this: if we have no problem treating one chronic disease for the rest of someone's life, why do we have a problem treating obesity for the rest of someone's life? So my feeling, and just because someone is their BMI is no longer high, that chronic disease is still there. Just because they're just a thin person with chronic weight gain, metabolic issues, rather than someone who isn't thin. And so that treatment, it may change, but there's no problem if it's for the rest of their lives. A lot, especially with the medications that are out, the GLP-1s, again, nobody cared when we had GLP-1 users for the rest of their life when they were diabetic. So why do we care if it's for people for obesity? And if
can I say too that people, I want the listeners to just really truly understand what you're saying, because Dr. Yolanda says something, that's really powerful, that we do got to make sure that they are not getting duped, that patients are not getting duped, that you're not paying all this money for these Energizer shots. I'm going to free somebody right now. If your B12 level is normal, the B12 shot is not doing anything for you. If your
even if it's not normal, you can go to CVS and buy the pills and take them.
You can buy the pills. You don't have to pay for it. Listen, it's okay. But people get it, and they pay money because they're desperate. They're desperate to get a solution. But don't be afraid to ask questions.
And don't think it's a magic shot.
Yes, it's not. There's no magic.
There's no magic. It's not. You still got to do work. It just makes the work easier.
Make sure that whatever your provider is going to give you, it's backed by evidence. Make sure that you're practicing with somebody who's backed by evidence. There are so many things out here, these generic medications that somebody will say, come into my clinic, get $99 and it'll work. And I'm not going to tell you that it won't work, but I can't necessarily to attest to what the side effects of it can be, because we don't know what these medications have in them, some of them. So make sure that if you're getting something, it's backed by evidence, that it's been studied, because it is a multi-million-dollar industry, and people can capitalize off of your vulnerabilities. And so you want to make sure that you're being very mindful of that and just being smart. It's okay to ask questions. It's okay to look it up yourself and go to a reputable source and make sure that whoever you're going to and whatever you're getting, that person is reputable and that they are trained and skilled, because we don't want anybody getting hurt because they're trying to improve their weight or improve their health.
And something someone also needs to people need to take into consideration. The FDA monitors all medications. As soon as a vitamin is added, it becomes a supplement. The FDA does not monitor supplements, and therefore anything can be in anything that's being given.
Right.
And so, but often what happens, that means thyroid medication could be put in it. And therefore, of course, you're going to lose weight when your metabolism is through the roof, because they've added medication to drive up your metabolism.
The proprietary blend.
Exactly. And so there's other things that can be added that can give weight loss, but aren't necessarily healthy, necessary, and the long-term effects, and so the best way to understand it is that if you start having problems, it's a problem.
Yeah. This has been amazing. And Dr. Yolanda's right. We could go on about this for 2 hours. If you guys, maybe I'll play it again next week. But Dr. Catherine Toomer came on, and her and I had a conversation, I think last year or the year before. And we told her story, which was amazing, because she has kept this weight off for how long now?
23 years.
So I'm telling you, it can be done. And she is a huge testament to the fact it can be done. So if you guys have any questions for any of these ladies, real quickly, ladies, please let everyone know how they can find you. We'll start with Dr. Yolanda.
My website is Dr. Yolanda MD, as well as, they can always email me info@dryolandamd.com.
Go ahead, Tiffany.
You can get me on any of my social media platforms. It's Dr. Tiffany Lowe Clayton or Dr. TLC. You can also email me at lowpain@campbell.edu. And if you're in the Raleigh area and you're looking, just look me up, Dr. Tiffany Lowe Clayton.
And I'm Dr. Toomer everywhere. That's DRTOOMER on Facebook, YouTube, everywhere except for TikTok, where it's Dr. Toomer Talks, because there was already a Dr. Toomer. But and you can email me at courage@drtoomer.com.
Thank you, ladies, so much. And next, we have a lovely conversation about caregiving. So please, everyone, stay tuned to Black Doctor. Bye.